So mantle cell lymphoma remains a very challenging type of lymphoma to treat. Current management strategies largely depend on the patient's age, whereas frontline strategies for all patients generally relies on chemotherapy and rituximab. If patients are younger, they'll usually go off to transplant after induction. And in both cases, at the end of treatment, most of the time, patients are receiving 2 years of maintenance rituximab as frontline therapy. The challenge really comes into second-line therapy and beyond, because we know that once patients relapse after frontline therapy, we have very little available to maintain any kind of durable control, particularly with respect to chemotherapy options. More recently, we have seen that BTK inhibition seems to be a very effective modality for mantle cell lymphoma, and in some cases, patients are now being treated with ibrutinib in the relapse refractory setting. So this year at ASH, we saw the data presented on the use of acalabrutinib in relapsed refractory mantle cell lymphoma. What we saw was a very large phase 2 study presented with over 120 patients. These patients clearly were multiply pretreated with a median of 2 prior regimens. So this is the exact kind of patient that we have difficulty controlling with standard therapies in mantle cell lymphoma. And the results were highly promising. So the overall response rates were exceedingly high at about 80%, and a large percentage of those, about 40%, were actually complete remissions. Obviously, we're still waiting for longer follow-up, but so far the median progression-free survival and overall survival hasn't yet been reached, and at the 1-year mark, approximately 70% progression-free survival was still seen. I think the safety profile reported with acalabrutinib is really quite impressive. One of the things we worry about in terms of toxicity of BTK inhibition, as previously reported, of course, is unique risks, which include bleeding toxicities and atrial fibrillation. The safety profile was highly desirable with acalabrutinib, with mainly grade 1, 2 toxicities seen. Interestingly, there were actually no reports of atrial fibrillation, and the risk of any significant bleeding was exceedingly low. I think this data clearly demonstrates the efficacy of BTK inhibition in patients with mantle cell lymphoma. I think acalabrutinib looks like a very well-tolerated drug, and may have a safety profile that is even more favorable than previously reported by other BTK inhibitors. So I think there's a high likelihood that this will be a drug that makes it into the Canadian landscape.